next speaker is our colleague, Dr. John Apostolidis, Senior Consultant in the Lymphoma Transplant sections at the MAM Specialist Hospital. He will talk about management of Hodgkin lymphoma on 2030. Goes with the government vision also.
Thank you. I would like to thank the organizing committee for this very honoring invitation. I'm really happy to be between colleagues. So I was given a difficult topic, and I will dare to say that the management of the management of Hodgkin's lymphoma in the next decade or so will switch to a personalized treatment approach based on the technology that's been innovative in the past few years, as we've seen, specifically molecular profiling, digital diagnostic pathology, and improvements in diagnostic imaging. So the purpose of this talk will be to look at briefly our current understanding and explore our current understanding of Hodgkin lymphoma, and I will focus specifically on these innovations and see how they can potentially remodel the way we approach the management of Hodgkin's lymphoma in the next decade. So we all know that Hodgkin's lymphoma is one of the big successes of modern oncology. And from the 70s, when ABVD was introduced as combination chemotherapy, a lot of patients were being cured. But in the recent years, we've seen innovative novel agents incorporated into the first-line therapy, and these are the large phase 3 studies in advanced Hodgkin's lymphoma that defined this period of introducing the novel agents into Hodgkin's, the Echelon 1 and HD21 studies, which incorporated brentuximab vedotin, an anti-CD30 antibody drug conjugate, and the SOHO KSA 1826, which incorporated nivolumab into the combination of AVD. I won't go into details of these studies because it's not the purpose of my presentation, but these studies have led to an incremental improvement in disease-specific survival in patients with Hodgkin's lymphoma. But we shouldn't forget that these combinations are associated with long-term adverse events, in particular solid tumors, cardiovascular disease, infertility, and neurocognitive, emotional distress and quality of life issues. And we should bear in mind that with the introduction of the novel agents, there is a time lag in recording these adverse events of patients, which makes it even more important that we should have proper survivorship clinics to detect these adverse events that will long-term with these new agents. So even so, with introduction of these novel agents, the backbone of the treatment is chemotherapy, and despite the introduction of these novel agents, around 20% of patients will eventually relapse after first-line therapy. So there are efforts to introduce novel agents, and those are highlighted in red. These agents specifically target the microenvironment, as you can see, the T regulatory cells, the macrophages, or the NK cells. And we're hoping that in the future we'll be able to incorporate some of these agents into the upfront setting, reduce the exposure to chemotherapy, and improve the long-term toxicity of these patients. Now, in Hodgkin's lymphoma, the success story is also attributed in part to positron emission tomography, because with positron emission tomography, we achieved more accurate staging of our patients. We achieved better assessment of end of treatment response, which practically led to less exposure to chemotherapy, but in particular to radiotherapy. And although this has a highly negative predictive value, we should not forget that it's not a perfect study, a perfect modality. And as you can see, it has intermediate value because it has a high false positive value of around 40%. And we should bear in mind that another approach would be to use the interim PET scan, which also has been shown to be very predictive of outcome. So if you do an interim PET scan, the patient is negative, it predicts that you will have overall a better outcome at the end of treatment. And studies have been introduced with adapted strategies after an interim PET scan. As you can see here, in particular the Raffles study, we all know if you had a negative PET scan after 2 cycles of treatment, you would omit bleomycin, and this did not affect the overall outcome of patients. On the other hand, you could escalate in these trials. Whoever failed, had a positive PET scan interim, would go on to escalated BCOP. So the value of interim PET scan actually has been challenged in the Echelon 1 study and in the SWOG study, because we know that these studies were designed not to look at interim PET scan assessment in these studies. But we should note that the HD21 study, which compared escalated BCOP to BRCAD, there was an interim PET scan in these patients, and if you achieved a metabolic CR, you would go on to only 4 cycles of chemotherapy. Now, we've tried to improve the prognostic value of the baseline PET scan by incorporating a variety of parameters, and one of these is the total metabolic volume, as you can see here. So you can see on the left-hand side 2 patients with stage 4 disease, but they have strikingly different TMTVs, as you can see, and based on a cutoff, you can predict. You have low risk and higher risk, and the 5-year progression-free survival ranges from 83% in the high risk compared to 91% in the low risk patients. In a similar fashion, it's been shown that the distance between the farthest hypermetabolic lesions can also affect the outcome. And as you can see here, we have 2 patients who have similar TMTV, but the Dmax is strikingly different between these 2 patients. And you can see that, again, the 5-year PFS ranges from 80% to 90%, depending on the Dmax. So there is a cutoff in this study that was presented at Lugano. And interestingly, if you combine the baseline TMTV and Dmax and the PET2 response, you can actually stratify your patients into 3 risk categories. Patients who have 0 risk factors have a 5-year progression-free survival, which is excellent, 94%, while those who have 3 risk factors, it's only 69%. So it's predicted that future software, actually, it's ongoing, and future software combined with artificial intelligence will be able to predict all the, automatically, process and give you these results, and you can actually stratify your patients using these prognostic tools. So we'll move to digital pathology. I mean, it's interesting because there's a shift towards complex multiplexing, which is co-localization of various markers in a spatial environment and using digital imaging to interpret what you see in the microenvironment. This is very important because it has strong implications on understanding the tumor microenvironment, identifying genome features, and also it has significant value in clinical practice. And the next slide is a typical example of how this approach can be used in Hodgkin's lymphoma. So this is a study from the BCC in British Columbia with Christian Steidel's group, and what they did is they used this platform, and they took biopsy samples baseline and at relapse, of patients who are going to go on to autologous stem cell transplantation. And the question they wanted to answer is, does the tumor microenvironment predict which of these patients are going to fail auto stem cell transplantation? So using this digital diagnostic platform, they found specific markers that are associated with outcome. And these were the CXCR5 expressed in the Hodgkin Reed-Sternberg cells, PD-1 positive CD4 cells, the CD68 macrophages, and CXCR5 B cells. And so they made this spatial biomarker, as you could say, with these 4 indices. And as you can see in the image on the lower right side, poor prognosis is those who express those markers, as I mentioned earlier. Good prognosis is those who had the CXCR5B cells. And if you look at the survival curves, progression-free survival and overall survival, striking difference depending on the microenvironment signature as determined by this spatial biomarker. So in the future, these could be used as predictive markers of response. Moving to cell-free DNA, I'm not going to go too much into it because Martin is going to look, it's a hot topic. I'd like to see what he's going to say about it. But so, this is a really hot topic now in lymphomas. It's a non-invasive procedure. It's genotyping, risk stratification, and a really important aspect of it is response assessment and MRD. And you can envision what implications this has for diagnostic and monitoring and treatment assessment of patients in the future. So using this technology, the German Hodgkin lymphoma study group used cDNA to subclassify their patients into 3 distinct subtypes. The inflammatory immune escape Hodgkin lymphoma, which has a copy number increased copy number variations of in particular the 9q24 region, in which the PD-ligand 1 and PD-ligand 2 reside. And as you can see, there's a hot inflammatory microenvironment in this category. The second was the virally driven Hodgkin lymphoma, in which there was expression of EBV or HHV6, and these patients had a low mutational tumor burden, and the inflammatory environment here was mainly consisting of neutrophils and macrophages, while the third subtype was the oncogen-driven Hodgkin lymphoma, in which you had overexpression of a tumor of mutation, the tumor mutational burden, oncogenes which are typically overexpressed, such as TNF-PT2, and this had a cold microenvironment, this subtype. So they suggested that you could actually use this to subclassify your patients and do clinical studies with patients stratified in these biologic subtypes. And as you can see, using ctDNA, they could see that if they were positive or negative, the outcome of these patients. Patients who were positive, based on ctDNA, did worse. And the worst actually category was the MRD positive was the inflammatory immune escape Hodgkin lymphoma, which was also the case, as you can see, in response assessment with a PET scan on the right here. So actually the first study looking at genotyping with ctDNA in Hodgkin's lymphoma was this study, was published a year earlier. This was from the Stanford group in an international collaboration. And what they demonstrated is that there are 2 subtypes of Hodgkin lymphoma, H1 and H2. H1 has a high mutational tumor burden, and it has activation of NF-kappa B and STAT. And these patients, characteristically, around 2/3 of the population, were predominantly young patients. They had an enriched cytokine response signature, and they had favorable outcome. The H2, that corresponded to the oncogene subtype seen in the German study group study. And also the H2, in which they had a low tumor mutational burden. There was increased genomic instability, EBV associated NF-kappa B activation, and amplification of PD ligand 1. These were a third of the population of the patients. They enriched, as I said, to EBV and MHC subtype, higher circulating tumor DNA levels, and inferior outcome. Interestingly, what they did is they also looked at they stratified their patients based on circulating tumor DNA and looked at the PFS, and just looking at the baseline circulating tumor DNA, they could stratify patients into low risk and high risk based on a cutoff which has been used in the diffuse large B-cell lymphoma studies done by the same group. And it's interesting to see that a third of the patients, just after one dose of chemotherapy, actually became MRD negative. If you look at cycle 2, day 1, 85% and more than 90% after 2 cycles of chemotherapy, which is quite fascinating. And so as you can see here, the PFS stratified by CT and DNA. You can see cycle 1, day 15, and also cycle 3, day 1. After 2 cycles, you can see, and this actually evolved over time until the 6th cycle, with a more than 90% progression-free survival rate in those who were ctDNA negative at the end of treatment. Interestingly, a similar approach was presented at the ICML meeting recently. They looked at the SWOG study and they looked at baseline ctDNA, and they observed that, again, the tumor burden at baseline can predict outcome based on the cutoff I mentioned earlier. They also demonstrated after 2 cycles, but also if you look at the trajectory of the reduction of the circulating tumor DNA impacts progression-free survival. So if you had negative ctDNA after 2 cycles, or you had a major drop, which was defined as more than 50% reduction in the circulating tumor DNA, you would have a very good outcome at the end of treatment. And again, here you can see end of treatment, highly strong association with MRD negativity. Here you can see that the end of treatment, ctDNA, 92% 2-year progression-free survival, so you have a high negative predictive value, higher than what we see with PET scans. So, based on that, what studies are running now? As you can see, this is a slide I made a month ago. I'm sure there'll probably be more of these studies coming out in the next months. So these are 2 studies. One is in the frontline setting. This is from the Fred Hutch. So they give nivo-AVD 2 cycles. If the patient is MRD negative, they give another 2 cycles, and then nivo 2 cycles. If he's MRD positive, the patient receives a nivo-AVD 6 cycles. There's also a study from the University of California in San Francisco. This is in the relapse setting. So they give Pembro GVD 2 cycles. If the patient is MRD negative, they stop the chemo. They just give Pembro 8 cycles with or without radiation. If the patient is MRD positive, he's off protocol, he's salvaged, and he goes down the traditional pathway of autostem cell transplantation. So it's very interesting. We're seeing now these kind of studies enrolling patients. So this is the last slide. So one can conceptualize a framework for individualized care, but also for clinical trials of Hodgkin lymphoma in the 2030s. This is from a very nice article by the Germans. So what you do is you look at the tissue combination, you stratify your patient based on all these things I showed you. You integrate your material, and you decide which type of treatment your patient is going to receive, type A, type B, or type X. And then assessing MRD by ctDNA, looking at biomarkers and potential quantitative PET response, as I mentioned earlier. You can decide how much treatment you're going to give to your patient and aim at giving the minimum number, the minimal treatment to cure the patient and to reduce the long-term toxicity of these patients. So with this, I'd like to thank you for your attention.